Yes, good afternoon and good morning, colleagues. It's Aftab from Country Office, and I will be sharing some gender-related work which we conducted as an integral part of our urban slum profiling and immunization coverage assessment. So this initiative was this activity was conducted as an integral part of urban health initiative, financially supported by Gavi. And this whole work was conducted in selected union councils and in 10 mega cities in partnership with civil society organizations and like civil society organization CHAPE, and there were some other CSOs which we involved in this work. So next, please. So as an overview, we know about Pakistan. I mean, it's a 220 million population, and mostly the urbanization is going to be a challenge in future. And at this point in time, around 36% of population is in urban areas, which is going to be 46% by 2030. And we have around 77 million cohort per year of newborn, and out of this, around 13 million people, they are living in urban poor areas in 10 largest cities. So that was the reason that to address these communities, with Gavi support, we identified 3 areas: the communities in urban poor, in remote rural areas, and security compromised areas. But this study was conducted only in urban slums, so that's why the findings will be presented from that study. So I will concentrate on the corrective action and corrective measures taken based on this finding due to this shortage of time. So when we conducted this urban slum profilings, around 1,300 slums were identified in 10 mega cities. According to UNIC 2018, we came to know that, okay, there are around 1.5 million zero doses are in this country. So to address those zero dose children, to reach them, we needed to know that who they are, where they are, why they are not reached, and how they can be reached. So we use the framework identified, target, and monitor. And in these provinces, and we find this is from PDHS, that we found that there's a huge inequities within provinces and within districts and within union councils and in those areas. So under social urban slum profiling, we conducted number one mapping. This civil society CHIP conducted this study in partnership with technical support of UNICEF, the profiling of urban slums, where in 2017, from 2017 we prototyped. In 2019 it was rolled out to all 10 mega cities. Immunization coverage survey, in those mapped urban slums we conducted this, and social profiling was conducted by 5 other CSOs in selected UCs in all provinces. So the method we used was qualitative and quantitative research, focus group discussions with community notables and with the healthcare providers. And this study identified this both supply side and demand side barriers, and we identified the local kind of evidence that what are the issue, why we have very low coverage, and how we can have a kind of gender sensitive action planning and programming to reach these communities. Next. So these were the findings in all those 10 mega cities, where we profiled 4,417 slums and underserved areas. And in these slums, the immunization coverage survey was conducted. Next. And when we conducted this immunization survey, we found that there's a huge inequities between the cities, and same was within this sub-district or union council level, starting from 27% in Quetta to 76% in Multan. This was in 2018-2019 data. Next, please. So when this immunization coverage also, and there was a huge sample based on WHO research methodology, which was developed in consultation with our WHO team. Around 4,000 children were sampled, and we came to know that 14% of them, and this survey was conducted only in slums areas among urban poor. And we came to know from this survey that 14% are zero dose, and we have 33% partially vaccinated dues and defaulters, and there was only 53% was fully vaccinated. Then in-depth analysis was conducted for these 14% of children to identify the reasons for zero dose children. Next, please. And we came to know that about yeah, if we see about the distribution of these zero dose children in those 10 cities, we were having lowest coverage in Quetta and maximum number of zero dose children. So that was the distribution in those 10 mega cities. Next, please. So when this study also revealed and that more than 80% reasons for the zero dose children were no permission from family. Vaccination causes more diseases and fear for injection. This family no family permission, it's 33%. It's a clerical mistake, not 29%. So more than 80% reasons were related to these three main areas. And then with our ACSM team, they conducted this social profiling where they had a kind of deep dive of this these reasons. Can we go to next? Yeah. So these were the main findings from our social profiling, which was conducted in all 5 provinces within partnership with 5 organizations. And the most important thing which we find that the males at the home, they have the decision making power. Like 86% fathers are the main decision makers in Balochistan. And if we link this to our coverage assessment, we have the maximum number of zero dose there and lowest coverage in Balochistan. So these inequities in power relation, and in Punjab we have 39% female, they have the decision power. So this inequitable power relation, it's not only affecting the immunization of female, but also the male child at home due to several reasons. Then they also, this family permission, at that, without family permission, they were not willing to vaccinate. Then social influences were considered significant in making vaccine related. Same is with like most of the caregivers in zero dose communities were illiterate and had basic education only. Then low trust on vaccination services and quality of services. Then there were some other reasons. They trust mostly on family, friends, and religious leaders. That was another findings. So based on these findings, we developed, number one, we used this evidence to inform policy and then develop kind of a costed action plan. So these are the findings which we discussed. In gender related, if we say 94% mothers do not have employment outside the home, as we discussed earlier in our representation. 33% children did not receive vaccines due to lack of family permission because the decision power is with male, and male is not at home during the day when teams are going there for outreach session, for integrated outreach sessions, or for campaign vaccination. So male, they used to come in evening. So that was kind of the local solution came out that we need to approach these male members of the family in evening. So we had a kind of strategy for this, and we implemented that one. Lack of decision making, we discussed this, and 64% in economics, 64% caregivers of zero dose children are working on daily wages. So poverty is the main issue in these communities. Environmental issues are there. Education, yes, 76% mothers of zero dose children were found illiterate, as compared to 47% mothers are fully vaccinated. If we see about the health services, we selected only gender related indicators from these studies. So 68% profiled areas have limited access to health facilities. Limited access mean more than 3 kilometers. They are not within the 3 kilometers of the health facility. and 58% profiled areas are not covered by LHWs due to several reasons. Number one, shortage of female workers, number one. Number two, if the health worker is going due to the legal status of these areas, and it's not in their outreach, in their catchment area, so and then due to security reason, they are not going inside to provide these services to these communities, and they are left unattended. Next, please. So it's the last slide. So based on these informations, we developed with the provinces the cost reduction plan, and we informed the policy at EPI policy development at federal level and for the country, where gender has been included, female workers have been included. All these communities were included in micro plan with them. Then the program initiated 24/7 birth dose initiative in maternity homes. Like in 38 sites were established in both in public and private sector, and female vaccinators was trained from those labor rooms, and they are providing services, and around 140%, which is 140,000 newborn were vaccinated in last 1.5 years, which is the 96% of the total newborn. Then integrated outreach services were started in during weekends and in evening shifts. Mobile vans were provided because we were having outreach issues, no sites in these slums areas. So now these mobile vans, they are taking integrated team, female worker to there and providing services. Then inclusion of LHWs in vaccination and social mobilization activities. And regarding ACSM, community engagement, evidence-based community engagement plans were developed based on the social profiling results. Then peer-to-peer kind of influences, mainly fathers, they were engaged to encourage other fathers for vaccination. Then engagement of grandfathers and all those things, and mother-in-law, and engagement of key influencers identified through profiling, key influencers, the community leaders and the religious leaders. Now, so with these initiatives, all these initiatives, they are, I mean, this gender assessment and all those things, that were not conducted as a separate project, but as an integral part of overall overall service delivery plan or improvement plan. So that was a kind of brief kind of reporting from ground zero. So questions are welcome. Thank you so much.